All right, so we're on to the upper extremity. Again, I just kind of off the top of my head threw on a bunch of random conditions here, try to get cases, at least one for each of the things listed on this slide that are likely to pop up on boards. And so we're going to buzz through about 60 cases here pretty quickly because it's about 2:30 a.m. and I need to get some sleep. So, all right. So what are we seeing here? First case, shoulder. Clearly, we have a glenohumeral dislocation, all right, and it's anterior, which is almost always the case. Yeah, so it goes antero inferior. So on the front of you, you know, it's hard to tell antero posterior. It's just a standard AAP. When the shoulder dislocates, it goes subcoracoid. Okay, the coracoid's anterior structure. So if it's up here underneath the coracoid, that's an anterior dislocation. In this case, they've managed to shear off the greater tuberosity. So this is a dislocation, and instead of getting a Hill-Sachs impaction fracture here, that fracture propagated through and actually just popped off their greater tuberosity. I don't see a Bankart lesion, which would be a fracture of the inferior glenoid rim. That's something else to look for. Here's probably the world's largest Hill-Sachs deformity, massive defect here. So they dislocated this inferior glenoid, impacted right here, and caused this defect, and then either they were relocated or maybe spontaneously relocated. And so this is a massive Hill-Sachs. And I mentioned a glenoid rim fracture, which is called a Bankart lesion, osseous Bankart. You can have a glenoid, a labral tear, which is a soft tissue Bankart. So there's a little fracture here. There's a little bit irregularity here. I don't know that this one's like not the best Hill-Sachs example, but there is a little Hill-Sachs lesion there. But the Bankart lesion is the more obvious thing in this case. And so these two things contacted one another. And so this is the result of a dislocation. All right, so this Bankart lesion often comes with a labral tear, may need arthroscopic surgery to treat. MR arthrogram is going to be the go-to modality to look for those, the extent of, non-osseous injury, or an osseous injury for that matter. But, all right, so this is more of a classic case of a Hill-Sachs lesion. This is what I typically see when someone comes to me or submits to me a film and says, hey, this person had a shoulder injury. We don't necessarily know what happened. Maybe they dislocated and spontaneously reduced. They've heard a pop. So we look at this x-ray. Did they dislocate? Yeah, they absolutely did dislocate. So this is a defect back here. So you kind of have to look through the humerus, through the humeral head, and look for the shadow. And then on the internal rotation view, all right, they're bringing that posterior surface, which is contacted the anterior rim of the glenoid when they dislocated. So looking at the posterior surface back here, and this is the defect. Okay, so it's kind of, there's a portion here that we're looking through, which is normal, but this extra line is the impaction fracture that occurred when the humerus hit that anterior rim of the glenoid when they dislocated. All right, so that's dislocation injuries. I skipped AC joint injuries, right? AC joint injuries often don't need to be managed surgically. They are in some cases, but not a big deal. Elevation of the distal clavicle is not that complicated. This person has some dystrophic calcification. AC joints otherwise look normal, a little degenerative. What's really abnormal here is the joint space is not good. Let's look at this last one, right? They had a dislocation, but their joint space is fine. They're a young, healthy person, right? This is what a normal joint space looks like. So freeze that frame in your mind. Look at this one. Okay, this is a uniform loss of joint space, like exactly the same distance across. So they have some inflammatory joint disease destroying this. Looks like they even have a little sclerosis or humeral head. I'd be a little suspicious of AVN, especially if they're on corticosteroids in this case. Looks like they have a little pec major insertional calcific tendinosis. And again, uniform loss of joint space over here. So this tells us they have an inflammatory joint disease, most likely RA. AS could do this too, I suppose. You need to see their spine, like to see their wrists as well. But yeah, so this is inflammatory joint disease in the shoulder. This is what it looks like. What are we seeing in this case? What we're seeing in this case, glenohumeral joint doesn't look too shabby. That's nice. Humeral head looks normal, greater tuberosity here, coming lesser, kind of a weird projection. The distal clavicle is abnormal. We follow this off and it just kind of tapers off into nothing. This is osteolysis of the distal clavicle. They've got some little wisp of something here. So osteolysis of the distal clavicle, also known as weightlifter shoulder, and when it's kind of idiopathic and related to exercise, this finding can also occur in inflammatory joint disease. So if you have RA, psoriatic arthritis, even infection, you can that often affects the AC joint and causes osteolysis. So that's the differential. Could this be a weightlifter shoulder? Sure. You'd have to correlate with the history. That often is managed conservatively. And if it's inflammatory joint disease, of course, you need to see a rheumatologist. Here's another example of osteolysis of distal clavicle. We follow this around, right? We should see a nice well-defined edge. We should see a joint space. So this is from here to here, all osteolysis. So this could be, again, inflammatory joint disease. Glenohumeral joint doesn't look too bad, so maybe not that. Looking at the film more comprehensively, also note that they have a cervical rib over here. That could pop up. You could expect some thoracic outlet syndrome. This would be a good case for boards because we got 2 findings here, so I could be very easy to write a question on this case. This one kind of tapers off. So tapering of the distal clavicle. Again, it's kind of same differential. Old weightlifter shoulder could be kind of chronic inflammatory disease that's eroded the distal clavicle. Those are the main things that could cause that old infection. This is a prior NFL player, so it's probably just old weightlifter shoulder. Here's an example of inflammatory joint disease again. Uniform loss of joint space. We got a little erosion here at the bare area of the humeral head, and notice the subacromial space basically gone. So this has led to release of their supraspinatus, probably a portion of their infraspinatus as well, and retraction, allowing the humeral head to migrate up. So inflammatory joint disease doesn't just destroy the articular cartilage, it can just destroy the surrounding tendons and ligaments, and this one's led to a massive rotator cuff disruption and proximal migration to the humeral head. And, left untreated long enough, that's going to look like this. Again, we have uniform loss of joint space, proximal migration, tapering the distal clavicle. So this is really extensive, long-standing inflammatory joint disease. They're severely osteoporotic. This cortex is paper thin. All right, so what are we seeing in this one? Everything looks perfectly normal aside from this thing. They've got some calcific tendinosis here. All right, hydroxyapatite deposition within the supraspinatus tendon. That's the most common site. So if you see any little bit of chalk floating up there, that's probably supraspinatus calcific tendinosis. It can occur in any of the rotator cuff tendons or pec, like in that other case we saw. So sometimes you have to look through the humeral head to see it over here, kind of in the infraspinatus coming around. Sometimes you'll see it adjacent to the lesser tuberosity in the subscap. So here's one. This is a scapular Y view, right? This is anterior. This is posterior. We can see the coracoid pointing us up here. So if this is posterior, this is infraspinatus, right? It's wrapping around here to attach this to the foot plate of the greater tuberosity. So this calcific tendinosis is in the infraspinatus. What are we seeing here? Not uniform loss of joint space, non-uniform loss in this case, right? It's narrow down here, but it's wider up here. So this is typical degenerative disease. We've got some sclerosis, subchondral cyst formation. We've got a big old osteophyte hanging off the inferior surface of the humeral head here. This is classic osteoarthritis in the shoulder. What are we seeing here? This is 2 cases of a pseudotumor appearance of the humerus. So when you see a humerus, sometimes you see this kind of loosened area in the greater tuberosity, and it looks like a tumor. It looks like a lytic lesion. That's a normal finding. It has normal trabeculation. And if it's here at the greater tuberosity, that's just that's called a pseudotumor appearance. It's a known kind of fake out. On this one, people could be mistaken that there's a lesion here too. So this is just where the humeral head attaches to the humeral neck. So it creates this border, makes it look like this whole thing's one big lesion, but that's just normal. So now getting into actual tumors, the most common thing you're going to probably see on boards show up in the shoulder as far as a neoplasm goes is a simple bone cyst. And I guess this isn't technically like a true neoplasm, but it's thought of like a neoplasm. It causes a big empty cavity here in the bone, usually filled with kind of serous or sanguinous or serosanguinous fluid. And these often present with path fracture because you can see how thinned out the cortex is. They're usually a little expansile. They're centrally located, so they're usually right in the middle, they expand outwards. They're metaphyseal or occasionally a little more diaphyseal. And you can see the cortical offset here, the fracture line propagating around. And the thing that really seals the deal on this, that this isn't fibrous dysplasia or something else, is that they've got these fallen fragments. So if there was tissue in here, these fragments couldn't fall into the chamber of the cyst. But it's a cyst, so they can. And so this is a simple bone cyst. It's a classic example. Here's another one, right? Well-defined lesion, proximal humerus, young person. These are all classic things for simple bone cyst. Could this be fibrous dysplasia? Sure, but it can't in this specific instance because we have a fallen fragment sign. And another little one over here. All right, so they presented with path fracture, fallen fragment. The only way this fragment can fall in here is if there's nothing in there other than fluid. What are we seeing in this one? This distal clavicle is missing too, isn't it? Is this osteolysis? Is this inflammatory joint disease? No. There's a big old expansile sulpal lesion here. This looks like a giant bone aneurysm because it is. So this is an aneurysmal bone cyst. What are we seeing in this one? This humerus has thickened cortex, has trabecular coarsening, and maybe a little bit of osseous expansion. This is a classic example of Paget's disease. That's the triad. So osseous expansion, cortical thickening, and trabecular coarsening. So this is kind of mixed to purely blastic phase of Paget's disease. When it's in the earliest phase, of course, it's going to be lytic, and advancing edge of osteolysis, those types of things. So you may see that in the shoulder. Here's an example of a malignant lesion. This is a metastatic breast cancer. You can see the kind of permeative, moth-eaten pattern of destruction, very poorly defined, wide zone of transition. Cortical destruction has led to a path fracture. This is a classic example. Could this be lymphoma or even multiple myeloma? It's possible. Multiple myeloma, we usually expect to see some degree of, punched out lesions, those types of things in classic cases. But there's a wide differential here. But almost certainly this is a metastatic lesion, and that's what it turned out to be. Here's another example of metastatic lesion. This one was a renal cell carcinoma here to the glenoid. Poorly defined cortical destruction. This is a case of lymphoma in a younger person. You can see all these kind of little moth-eaten pattern of bone destruction throughout the proximal humerus here. A little more permeative down here, very poorly defined. You can't really tell where it starts or ends. So that's lymphoma in this case. There's something else that's going to mention on this one. Oh yeah, so they have some lung stuff over here too. You can see they've got some kind of infiltrative lung findings. Looks like consolidation. This is I think lymphadengic spread. This is a typical appearance. This isn't a Hill-Sachs, right? This is normal transition to the greater tuberosity. AC joint looks normal. All right, so what are we seeing in this one? This one is a case of multiple myeloma. Look at this punched out lesion. Another punched out lesion there. Another one there maybe. That's probably some calcific tendinosis in their infra or subscap. They got a little irregularity up here, maybe degenerative, not a big deal. Distal clavicle doesn't look great, maybe old AC joint injury. Again, all these pale in comparison. What we want to be identifying here is the kind of permeative moth-eaten destruction, a few punched out lesions. We should favor multiple myeloma in this case, and that's what it turned out to be. Here's a case of a young person. We've got a blastic lesion, some hair on end periosteal reaction, a big soft tissue mass with some mineralization, permeative moth-eaten destruction extending down the humerus. This is an osteosarcoma. Could this be an Ewing sarcoma? That's a reasonable differential. Could be osteomyelitis. That's not a great one here. That usually has a more solid periosteal reaction, kind of involucrum formation. So this is almost certainly an osteosarcoma, and that's what it turned out to be. This one, we look at this. Glenohumeral joint looks normal. This is a young child, of course. Physeal plate's open. Acromion hasn't ossified yet. All that looks fine. What we're seeing here, again, is a very permeative area of lytic destruction, and then we've got this overlying laminated periosteal reaction both medially and laterally. This child had an Ewing sarcoma of their humerus. What are we seeing in this one? The humeral head here doesn't look normal. We can't really see it's not a Grashy view. We can't see the glenohumeral joint that well, but the humeral head doesn't look normal. We've got this area of sclerosis with overlying lucency. This is AVN, right? It looks just like AVN in the hip. And the reason they have AVN because the radiation port for their lung cancer came up through here. So they've got this lung lesion, some atelectasis, and so this is like a, probably a Pancoast tumor or something like that. And it just happened, the radiation happened to cause AVN in their humeral head. And, that's one of the causes. There's a long differential. You can look up your plastic Rags differential. That's the mnemonic. Does this person have some, this is mostly just degenerative. This is looking a little dishy here, but, it doesn't quite meet the criteria. Here's another example of someone with AVN in their humeral head. I believe this was someone on lupus treating with high-dose oral corticosteroids. All right, so what are we seeing in this case? When we look at an elbow, the classic thing you want to look for is the sale sign, because that's going to tell you of a joint effusion. It doesn't necessarily tell you what's going on. It's usually trauma, radial head fracture, but nonetheless will tell you if there's swelling intra-articularly in the elbow. So there's anterior fat pads being lifted up, posterior fat pads being lifted up. So we have a joint effusion. In the context of trauma, it's probably a radial head fracture. And in this case, we can see that radial head fracture right here. There's a little, that's a bad arrow. That's a little divot in the radial head, this line. I'm going to cover it up with my blue line. So that's it. So you can put a chisel on there. I'm going to draw a little chisel here, right? And you just went tink right in the radial head, and that's causes big joint effusion. So that's the most common cause of a joint effusion in trauma in the elbow in an adult. And so that's the thing you're looking for, is a little kind of cleft of lucency and a joint effusion. Sometimes the joint effusion's gone because people often wait a few days, even a week or two in some cases, because they think it'll get better and it just doesn't get better. And so you might only see this little lucent line. In this case, we have another fracture. We have a radial neck fracture. You can see there's a little cortical offset right here, kind of some abnormal density coming across. We don't really necessarily see the exit on the other side. Oops, my baby monitor's dying. Let me plug that in. All right. So they have a radial neck fracture. You know, see, they don't really have a joint effusion here. The anterior fat pad isn't too elevated. We don't see the posterior one. So it's probably subacute. They do have a fractured olecranon enthesophyte, triceps insertion, right? Getting a little enthesophyte here. It looks like that thing's fractured. If we could window level this maybe a little bit, if we weren't in PowerPoint, we might see some olecranon bursitis overlying. This is a young child's elbow. They've only managed to ossify their capitellum, so they're very young. But they have elbow pain. We don't really see a sale sign in this case. Not the best radiograph, but when we have a child with elbow pain, we're worried about a couple, common things. Radial head dislocation, which radial head lines up the capitellum here, so they don't have that. The most common fracture they suffer, though, however, is a supracondylar fracture. And so how do you check for that? Well, in this case, of course, we can see the cortical offset right here. That's not too hard to identify. But the way you can more objectively assess for that, because oftentimes you can't see the fracture or anything suggesting it, is the anterior humeral line. So you draw a line down the anterior humerus. It should intersect the central third of the capitellum. Right? So if I draw the capitellum here, anterior humeral line is completely anterior, and that's because this thing has bent backwards and it's brought it out of that line. So this is the fracture right here, and then this portion bent backwards. So that's essentially what happened. And so that's a supracondylar fracture, so that needs to see an ortho, casted, etc. Here's an example of radial head fracture, like I just mentioned, right? If you draw the line down the radial neck there, through the center of the radial head, this should intersect the central third of our capitellum here, and completely misses. So this is an anterior radial head dislocation. Nursemaid's elbow, pulled elbow. Here's an example of a little leaguer's elbow. They're doing some chronic repetitive thing that, tensions on their wrist flexors, and they've avulsed off their medial epicondyle. Okay, so this is way too wide, this physeal plate. It should be a nice thin line with two parallel surfaces, not this kind of asymmetric widening with distraction. So this is a little leaguer's elbow. Here's an inflammatory elbow. So this person has uniform loss of joint space, poorly defined articular margins. This person had RA. You can see they've got a little joint effusion here. You can see the posterior fat pad, which is bad. So this is a kind of a chronic, long-standing inflammatory joint disease with destruction. If the history fit, if they had more acute symptoms, fever, etc., shorter duration of pain, this could be a septic joint as well. Here's a more typical example of a inflammatory elbow. You can see they've got a big joint effusion, so they're having an acute, swelling, non-traumatic swelling. If this were, again, inflammatory joint disease, if it's monoarticular, you do worry about infection. But this is a person with RA. People with RA can get infections as well at a higher rate than the average population. That's something to keep in mind. So what are we seeing in this case? So when we're looking at the elbow here, of course, I'm going to start with the sale sign. We don't see that. Okay, so no sale sign. Radial head looks normal. Alignment's good. Anterior humeral line, that's good. Got a little degenerative electron enthesophyte, but we don't want to forget the soft tissues out here. This is a big old gouty tophus. So this person has gout, and over the olecranon is a common site. In the olecranon bursa to deposit uric acid crystals and create a tophus. So this is what a gouty elbow looks like. All right, so now we're getting into wrist and starting with trauma. Very common to fracture your distal radius. When you're an adult, one of two things happen. If you kind of foosh out with your hand, straight up in front of you, that impact is going to push your wrist back and fracture through your radius and cause dorsal angulation. So this is a Colles fracture. So posterior angulation fracture, you can see it across. This is very obvious. They're not always this obvious, but I'm showing you obvious cases. They have a little ulnar styloid process fracture here. No one cares about that. So this is a Colles fracture. And so compare that and contrast that with a Smith's fracture. So this is a fracture of distal radius as well. It's kind of a fall in an outstretched hand, but your hand's not like straight in front of you. It's like you're carrying boxes and you tripped. And so you're hitting the back of your wrist and it's forcing it up like this, and that fractures it and causes this anterior angulation. Okay, so this is fractured anteriorly, angled anteriorly, I should say. And so that's a Smith fracture. So the other one was Colles. This is Smith, just based on angulation. In kids, when they foosh, their bones are malleable, and so they bend and often buckle, and sometimes they'll fracture on one side. So if it buckles and it doesn't like have a straight up fracture, that's a torus fracture when it kind of circumferentially goes around. So this is like a kind of a Smith type with anterior angulation torus fracture. You can have buckling back here and bent cortex. You can see some abnormal density kind of traversing where that buckle is. And this is very common. I get cases sent to me all the time from docs who are worried about a fracture in kids. And this is what happens. I personally had one of these when I was a kid. It's very common. And so then to compare that, this is a green stick fracture where it didn't buckle. It actually broke, but it didn't make it all the way through. So we have some intact cortex on the posterior and medial surface or ulnar side, but we do have some actual focal cortical offset here. So this fracture kind of only came partway across. So this is a typical green stick fracture. It's very similar to the prior case. All right, so in this case, this is a typical example of a scaphoid fracture. So in your proximal carpal row, you do have 4 carpals, but you don't really see the pisiform, so you can just narrow it to 3, triquetrum, lunate, and scaphoid. Okay, scaphoid looks pretty normal in this frontal projection, but on the oblique here, we have an extra line here, and so you could mistake that for a joint if you weren't being careful. So this whole thing is our scaphoid, and this is a fracture through the scaphoid. Here's another example of scaphoid fracture. Again, you can see there's some abnormal density here, and then on the oblique view, sometimes ulnar deviation, whatever view you see it on, we have to see this lucent line, usually traversing the waist. It can be a little more proximal or distal, it can be anywhere, but this is a typical example of a scaphoid fracture. Here's a triquetral fracture. And so as triquetral fractures manifest, it's a little flake of cortical bone that's been avulsed off on the dorsum of the wrist. And so this one's kind of an oblique lateral. But we can't really say definitively where this is coming from. Scaphoids here, lunates here, so this has to be the triquetrum. But if you see a little fleck of bone along the dorsum of the wrist in the context of trauma, that's a triquetral fracture. So you should not miss that. What are we seeing in this one? Well, our proximal carpal row looks weird. Lunate shouldn't look like that. That's a pi sign. We look at the lateral here. Lunate's tipped out. Okay, so lunate's been kicked out. This is a lunate dislocation. So the capitate's coming down here. It should be sitting in the cup of the lunate, and it's not. So this is a lunate dislocation. You can also have a perilunate dislocation where the lunate stays articulating with the radius, but the capitate has actually jumped out. So if the capitate jumps out, that's a perilunate, and if the lunate ends up tipping out like this, that's a straight up lunate dislocation. This one is showing a very commonly missed finding in wrist trauma, which is a widening of the scapholunate joint. So they tore their scapholunate ligament. And that may not seem like a big deal, but that capitate's going to drop in there and cause a slack wrist, which stands for scapholunate advanced collapse. And so the collapse is this thing falling in, and that just wreaks havoc on the biomechanics of the wrist, precipitates severe degenerative disease. So you don't want to miss this. So on a wrist radiograph, one of the first places you should look is, well, first look at the scaphoid, make sure they don't have scaphoid fracture. The second place, look at this joint. Okay, these are the 2 most common things. And then the third thing you want to do is look at your lateral to see if there's a triquetral fracture. And once you've done those things, you've pretty much covered your common carpal trauma injuries that are likely to show up on boards. All right, so this is a hand X-ray. I've zoomed in a little bit here on the finding. This is a typical metacarpal fracture fifth. So they hit a wall with the side of their hand, or they punch someone poorly. Some people call this a barroom fracture. Other people call it a boxer's fracture, a bad boxer, I guess. But this is a typical metacarpal fracture at the fifth. Here's another one. You can see we've got a mid-shaft fracture of the third metacarpal. And sometimes these will, display straight up posteriorly or anteriorly, or may not displace much at all. So you need to make sure you're looking very carefully. Sometimes you only get that spike on the lateral projection. They have an ulnar styloid process fracture as well. All right, so what are we seeing in this case? When we're looking at thumb trauma, the 2 main things we're thinking about are gamekeeper's thumb, and that looks fine, right? This is just normal sesamoid bones. You have 2 of them. You can't really see the other one that well. But we look at the base of the thumb here, and it doesn't look that smooth. It's a little irregular. And now we see on this one, we actually do have a focal area of cortical offset. So this is a Bennett fracture. They fractured the base of their thumb. And so you want to make sure you're looking carefully at that. It's very frequent to have big old degenerative osteophytes here in older age. But this is actually a very common site of fracture as well. So that's a Bennett fracture. If it's comminuted, if it's like all messed up down here, that's our Orlando fracture. This is an example of a gamekeeper's thumb, right? So we look at the base, right? This is what it should look like. But this shouldn't be there. So they've avulsed off their ulnar collateral ligament. This is a gamekeeper's thumb, or skier's thumb is another name for it, where you have a hyperabduction injury. Thumb gets bent out, tractions that ligament, and avulses it. And so you want to make sure you're looking for that. The other thing that you'll notice here, if you're going through your carpals, like I told you to, their lunate should be here cupping the capitate, shouldn't it? and it's not. It's tipped out here. So this is a lunate dislocation with a gamekeeper's thumb. So this would be a great case for testing you on boards or something, because you have 2 findings to make. But both of these are going to be managed similarly. You need to go to ortho. This one's not really that displaced, so they probably will just put a thumb cast on this one, but this requires surgical reduction. Here's another example of gamekeeper's thumb. See these all the time. So again, they've avulsed off their ulnar collateral ligament. Other name is skier's thumb. I don't think they're going to test you on stentor lesion. That's something else. If you have spare mental energy, you can look up. This is a mallet finger. So if you fracture off the posterior aspect of the base of a distal phalanx, that's actually where your extensor tendon inserts. And so if you fracture that thing off, it's going to pull that off. And that's a mallet finger, and it causes this little flexion deformity because you can't extend your finger because your attachment, isn't there. So kind of a persistent flexion of the dip after trauma. That's a mallet finger, and then on X-ray we see this. So this needs to be braced in extension so that this parents up and is allowed to heal without excessive tension from the extensor tendon. Here's an example of a wrist where we've got a sclerotic lunate. It's getting fragmented, irregular. We can see that fragmentation of the articular surface. And so this person has Kienbach's disease. So they have AVN of their lunate. What could this be caused from? One of the common causes is negative ulnar variance, but they don't have that. They actually have a little positive ulnar variance. Other common cause is lupus on steroids, but any of our plastic regs for AVN differential fits. All right, going to neoplasm. The only real neoplasms you have to worry about in the wrist are, degenerative cysts, which isn't a neoplasm, but and enchondromas. So the most common benign tumor of the small bones, the hands and feet, is an enchondroma. So basically, if you see any kind of subpublicate lesion, that's what you want to call it. And so this one has a path fracture. This one has some pocket and calcification is telling us it's there. It doesn't cause a significant amount of endosteal scalloping, probably not a big risk for path fracture. This one. Big old subpublicate lucent lesion. This one does cause some cortical thinning. That one potentially is going to cause a path fracture at some point, and it has some popcorn calcification here essentially. It may not, just depends on what they do. Here's an example of the only real congenital thing I'm going to mention in the wrist is it's, not terribly uncommon to have coalition where you have congenital fusion of some of your carpals. It's almost always the lunotriquetral joint. And so, and this one, it looks like one homogeneous mass here. You might say, okay, well, maybe just projectionally we're not seeing that joint, and that's fair enough. But on this oblique view here, you can say, definitely this is fused. It almost tried to form a joint here, but it stayed all as one. So this is lunotriquetral coalition. This is a case where, look at it, they're a little osteoporotic, and the cortex looks a little ratty here along the radial surface. And even the terminal tufts here are getting resorbed. So this is someone with hyperparathyroidism causing reabsorption along the radial side and terminal tuft resorption. The other, main differential you should consider for boards when you're talking about acroosteolysis, where you have resorption of the terminal tufts, is scleroderma. And so this is a patient with scleroderma where they have reabsorption of the terminal tufts because their skin is becoming tight and leathery of the tips, causing resorption. They also have some other, arthriticity change here at the fifth tip. Here's just another example of acroosteolysis in someone with scleroderma from Radiopedia. What does this person have? Well, we look at this. Their wrists look all messed up. They got some uniform loss of joint space. Looks like they have some actually rotary subluxation deformity of the scaphoid here with proximal migration. They probably have some kind of rheumatic Terry Thomas sign there leading to slack wrist. This is someone with RA. Okay, so if you see an inflammatory joint disease involving the wrist, you should think RA. By far the most common. This one's a bit more extensive, especially on the right, more so on the left, so it's not as bilaterally symmetric as we'd like to see. And then we've got all these marginal erosions, which are quite severe here. This one's a little bit more prominent in the PIPs, but this is another case of RA. Okay, uniform loss of joint space throughout the wrist. Just looks a little gnarly. What is this case? Wrist looks fine, so we're probably not thinking RA. They do have arthriticity changes here, though, which are destructive. Resorption of the articular surface, pencil, and cup deformity. That's a finding we see with psoriatic arthritis and arthritis mutilans. So it really destroys the joint here, and it's a little bit more haphazard in its distribution than RA, which tends to be a little bit more bilaterally symmetric, especially in women. They got a bone island here in their fourth distal phalanx, which is no big deal. That's the case of psoriatic arthritis. Here's a case where you see some extensive alignment abnormalities that you would usually associate with RA. We've got a hitchhiker's thumb here, ulnar drift. We got a swan neck deformity. And so these are two different people, by the way. Dislocation of their base of their CMC joint here. And so this is lupus. So if you see all the changes of RA, but you don't have any erosions, so something that looks like RA sans erosions, that's typically lupus. So it's a non-erosive deforming arthropathy. That's the thing you want to memorize. This one you could argue, okay, they do have uniform loss of joint space. I'd agree with that. I don't necessarily see any erosions, maybe a little one here. So this person did have lupus, but it's a little more RA-esque. But they need to see a rheumatologist in any case, so you get the management right. They have a little scapholunate widening, right? Don't forget to look at that. So that could lead to slack wrist. All right, well, that's the end of upper extremity, so I'm going to stop this, and tomorrow, hopefully, I can get some lower extremity cases recorded for you.